Welcome back to Medication Management in Patients with Advanced Illnesses. This is Module 3, Non-Pain Symptom Assessment and Management, Part 1. I'm Dr. Diana Stewart, and with me I have Dr. Lynn McPherson and Nicole Brandt. The objectives for this module are to be able to describe the presentation and common causes of gastrointestinal and genitourinary symptoms at end of life. That's quite a mouthful, so for the rest of it, we'll just refer to those as GI-GU symptoms. Given a patient case, identify some red flags for GI-GU symptoms, and list one medication and one non-medication treatment for these symptoms. Just a brief outline for Part 1, we'll be discussing anorexia and cachexia, dehydration, constipation, as well as nausea and vomiting. Starting out with anorexia and cachexia, I always like to provide the definitions for these two because I find that patients will commonly interchange them and think that it means the same thing. But anorexia refers to the loss of appetite and a loss of the desire to eat. And this will actually occur naturally throughout the course of many advanced illnesses. And it's nearly always present in advanced diseases and at end of life. Cachexia refers to the wasting or weight loss and loss of muscle mass and often occurs with weakness. So this is a pretty common question. What caused what? A lot of people think that cachexia, or the wasting, is a result of the anorexia, or the loss of the desire to eat, but it's actually the reverse. So what we find is that in advanced illnesses, there's a change in the body's ability to use the nutrients that you get through nutrition, and you develop this weight loss. As a result, you lose the desire to eat. So actually, the anorexia is a consequence of that muscle wasting and weight loss from cachexia, but it's not really an intuitive process. Here's a laundry list of some common causes of anorexia and cachexia. This could be due to some of the common psychological conditions such as depression or anxiety, medical conditions such as brain tumors, stroke, or even stomach and esophageal cancers, which could cause a mechanical obstruction to eating. Infections, so anytime I am sick with an infection, I feel pretty crummy and don't really feel like eating, as well as drug-induced, so chemotherapy is a pretty common one that people think of. And then the presence of other symptoms, so if you have persistent nausea or mouth ulcers with taste changes, you'll probably lose your desire to eat. And then some other physical things could include the loss of teeth or poorly fitting dentures. And actually, we had a palliative care patient this week. We actually submitted paperwork to get them new dentures, so hopefully that all works out. Some of the signs of anorexia. So anytime you're looking at a patient, these are some indications to speak to the nurse or prescriber, particularly if you see an increased level of weakness or an inability to perform normal activities of daily living. If the patient has not had a bowel movement in 3 days or is having difficulty having a bowel movement, weight loss, as well as reports of a sore mouth or throat, as well as heartburn, and if patients report feeling full even if they just eat a small amount of food. And this can be accompanied by sad mood or depression, even if it's reported by caregivers. And again, the presence of dry mouth, chapped or cracked lips. How do we treat anorexia? So some of the things that we consider early on in the disease state include a dietary and nutrition consult. We love to refer to the experts, and definitely dietary and nutrition are the people to go to with questions about anorexia and cachexia. It's important to monitor the patient's food intake and their weight. And you can consider the use of appetite stimulating medications, which include the steroid dexamethasone or Decadron, or Magestrol, or Megace. But Dr. McPherson, what do you think about the utility of these agents in advanced illness?
Well, I do like dexamethasone. I think that's a wonderful drug and it treats multiple symptoms, provided the patient doesn't have glucose intolerance, such as pretty significant diabetes, or they have a serious gastrointestinal issue, such as a recent bleed. I'm not a big fan of Magestrol. It's an estrogenic compound that increases the risk of a blood clot. It doesn't work very well. When people gain weight, it's usually fat, not lean body mass. So it's not a particularly useful medication.
And just to add to that, Magestrol is on the American Geriatric Society Beers criteria of medication.
So it's a naughty kitten, isn't it?
Yeah, it's one of those ones you try to avoid because the evidence and the benefits of it aren't really that great. So again, reinforce your perspective there.
Absolutely. Some other options for treating anorexia, again, intense dietary and weight monitoring is rarely necessary for patients on hospice because this is a consequence of their advanced illness, not necessarily due to an absence of food. The goal should be eating for pleasure. So, Dr. McPherson, what kind of phrase would you use to talk about eating for pleasure at end of life?
Just this morning I said I hope to die by choking to death on a donut, but that's just how I roll. But I'm curious, Dr. Brandt, we have so many regulations in long-term care, particularly about weighing patients and following their progress, and oh my gosh, what if they're losing weight? How is this addressed when it's a hospice patient?
Well, just as we talked about liberalizing labs and laboratory monitoring, not taking weights is something, or not doing it as intensely, and also as we look at goals of care, right?
Great.
So, important.
And sometimes we put a lot of pressure on patients to eat because if you cook your meal for a loved one, you'll feel hurt if they don't eat it, especially because a lot of people show caring through providing food. And of course, nobody wants to see their loved ones starve, but it's important to counsel patients that giving artificial nutrition and hydration at the end of life is usually not appropriate, and unfortunately, it will not help the patient gain weight or feel better.
And just to add to that, Dr. Stewart, Dr. Finucane's done a lot of work in this area in advanced dementia and artificial nutrition and hydration, and just really, again, looking at that benefits and risk. So, important to note that.
But a huge educational point, because families do get stressed out about this.
Absolutely.
Yeah.
And stressed.
When my dad was terminally ill, my mom would spend like 8 hours making dinner. Literally. It was like the cover of a magazine type cooking. And he would try so hard to eat a couple, 3 bites, and he would be full, and she would just be so upset. But just explaining that, this is what happens when you're very ill.
And some of the kind of middle ground that you can recommend for patients is to make food available. And certainly if a patient's eating, we never want to deny them nutrition or food. So make that food available if they want it, but never force it on a patient. And sometimes providing smaller plates so the portions don't look quite as huge can also be helpful. Let's get into a case study. Becky is visiting her mother, Miss Lee, at the nursing home. Miss Lee has advanced stomach cancer and dementia. After the visit, Becky mentions to you that her mother is practically skin and bones, and she would like for the staff to start feeding her mother larger meals. So, Dr. Brandt, what might be some appropriate counseling points for Becky about her mother's weight loss?
Oh, so as we're going through this in process of elimination and focus, let's look at A. Anorexia and cachexia at end of life is usually due to the patient's desire to look slimmer. No. Right? No, they're not worried about their looks as much as their comfort. Unfortunately, there is nothing the staff or medical team can do about Miss Lee's weight loss. That's not necessarily true either, as we just talked about some of the different tactics, whether it's medications or non-medications. The staff should encourage eating for pleasure. We just talked about that. So we want to encourage at a time that's convenient when she's ready, but larger meals with someone with her prognosis and her medical conditions would put her potentially very uncomfortable, right? Mm-hmm. So definitely C would be my choice.
Let's take a look. And it looks like C is the correct answer. Moving on to dehydration, this refers to a reduction in the overall water content in the body, and it's a common condition at the end of life. Just looking at this picture makes me thirsty. So dehydration and decreased fluid intake is the loss of desire or ability to drink fluids. And it also may be due to an abnormal loss of fluids through other activities such as vomiting, diarrhea, really watery stools, or increased frequency of urination. Benefits of dehydration. What does this mean? Is dehydration ever a good thing? Well, what we've found is that dehydration at end of life may actually decrease a patient's incontinence and reduce the chances that they'll need a catheter. And Dr. Brandt, I think there are a lot of kind of issues surrounding catheters, especially in older adults. What are some of the things that we worry about with putting a catheter in?
Oh, absolutely. Just think about you're taking a foreign object and putting it in an uncomfortable place. So the pain, the potential for it not being placed appropriately, if your patient becomes delirium in the latter stages of, they might yank on it. And of course, the increased risk for infection. So there's a lot of concerns regarding catheterization, and people think even external might be better, but there's still risk in terms of skin breakdown and discomfort.
Absolutely. So in patients who are dehydrated, that reduction in urine output could avoid some of the complications associated with a catheter. It can also reduce the cough and congestion due to pulmonary secretions or fluid in the patient's lungs, and decrease nausea and vomiting if this is due to high levels of gastric fluids. And actually, we found that dehydration can actually reduce a patient's pain. If patients have pain due to swelling around tumor sites, then this could be a potential relieving factor. And there's actually a potential natural anesthetic effect from dehydration itself. How do we manage dehydration? So if you do choose to promote rehydration, first we want to encourage oral rehydration, and again, avoiding any plastic or the insertion of lines to provide artificial hydration is important. The use of artificial hydration, especially at the end of life, is controversial. So on one hand, you may relieve symptoms that impact the patient's quality of life if they're suffering from the dehydration. And I think really the big component is that providing this hydration relieves the emotional distress of caregivers. Just like caregivers don't like to see their loved ones not eating, they feel like they're starving, we never like to feel like we're withholding liquid from patients. But again, providing artificial hydration can actually worsen discomfort. It comes at a cost to the patient and the healthcare system, and also it adds complexity to their healthcare routine. So if they have to have IV lines changed at regular intervals, this is just one more thing that the patient has to go through.
So I'm curious, when you say artificial hydration, just to make sure I'm really clear on this, are you talking about IVs?
It could absolutely include IVs, and we get these questions a lot at end of life. Just because we aren't pursuing curative treatments, of course you put a PEG tube in my mother and provide nutrition and put an IV line in to maintain hydration. Isn't that what you would want?
I don't think so.
And like we talked about, dehydration can actually have a benefit for some of our common symptoms. So if you provide that artificial hydration, you might cause or worsen symptoms from edema, ascites, which is swelling in the belly, nausea and vomiting, or pulmonary congestion and difficulty breathing. So what is artificial hydration? Like we mentioned, this is a decision to administer fluid based on a thorough physical assessment and a comprehensive review of the benefits and burdens of therapy. So it's not something that we just throw on because. Hydration can be provided as an injection into the vein, muscle, or subcutaneous tissues, but none of that really sounds very comfortable to me. Next, we'll talk about one of our favorite topics, constipation. And the definition of this varies depending on what the patient's normal bowel pattern is, so there's no definition that applies as a blanket statement to all patients. It could also refer to infrequent bowel movements that occur less frequently than what the patient normally experiences, or less frequently than once every 3 days. Constipation can also involve bowel movements that are difficult to pass due to hardness. Dr. McPherson, what do you think about this disgusting Bristol stool chart?
Well, you know me, I do love a good Bristol stool chart. This is a way to assess how hard the patient's stool is. So as you can look at type 1, somebody had to strain pretty darn hard to produce those separate hard lumps, so they come out like little nuts. Type 2, which you've got a little bit of coalescence going in there, is kind of a sausage-shaped but lumpy hard stool. Type 3 is heading a little bit more toward normal. Type 4 is the holy grail. It's like a sausage or a snake. It's smooth, it's soft, it just kind of slides right out. Type 5, now we're on the other side of the scale, the other side of the mountain here. We're turning into soft blobs. Type 6 is fluffy pieces of stool. And type 7, boy, you are in the splash zone there because it's all watery and no solid pieces at all.
I hope you aren't listening to this module over a mealtime. Some of the common causes of constipation can be from tumor burden that compresses the GI tract or colon cancer. It can also be due to some of our treatments, especially medications. And like we talked about in Module 2, opioids are a common cause of constipation, and like we mentioned, that constipation will not go away over time. It's common in neuromuscular diseases such as multiple sclerosis, ALS or Lou Gehrig's disease, and diabetes, and also hemorrhoids. Other causes include decreased food intake, so if you aren't taking a lot in, you probably won't have a lot out. And we talk a lot about fiber content, and this serves really to bulk up the stool and make them easier to pass. Patients who are unable to maintain adequate fluid intake, again, this can impact the hardness of the stool and how easy it is to pass, and even lack of privacy, especially in a hospital if patients don't have private rooms. This may really impact their ability to go. If patients experience significant pain when trying to pass a bowel movement, this can lead to constipation. And general weakness and use of opioids.
So, Dr. Stewart, if people aren't eating at all, do they ever have a bowel movement?
So you could still have bowel movements, I think thin ones from just gastric secretions that are produced normally.
Sure, you're still sloughing off GI cells. It might not be very often, but they do still have occasional bowel movements, yes.
That sounded like a trick question.
Well, but I wasn't able to stump you like you did me earlier.
So some signs and symptoms of constipation that anybody can look out for. Always report to the nurse or prescriber if you observe a change in the patient's normal bowel pattern. And again, this could be a bowel movement that occurs once every 2 to 3 days, or if the patient tells you that they've been straining or passing hard or small stool. If patients are experiencing nausea and vomiting that don't seem to be due to other causes, this could actually be from constipation. If you have all of that bowel backing up within your stomach, it'll compress your stomach and really make it difficult to tolerate anything in your stomach. And again, the presence of all that stool in there can cause abdominal pain, and sometimes patients will just report this as a general feeling of fullness or bloating. And you can also get oozing of liquid stool that will come out from around an impaction, and that's never a fun thing to experience. And again, increase in gas without the presence of a bowel movement may indicate that the patient has stool that they're unable to pass.
Boy, that fecal impaction can be tricky. Somebody might think they're having diarrhea, but they're really constipated. That's tricky, huh?
That's like a double whammy.
It is.
How do we treat constipation? So, Dr. McPherson, what do you think about stool softeners such as Dulcolax or Colace?
If we're looking at stool softeners such as DocuSate, they sort of function like as a detergent. They draw some fluid into the bowel. They're okay if they're not taking an opioid. So it's okay for garden variety constipation, but if someone is taking an opioid like morphine or oxycodone, it's not going to get the job done. That's when you would use one of your stimulant laxatives.
Yeah, I always think of stool softeners as like the little leagues, but if you really want to go with the big dogs, stimulant laxatives are the way to go. This includes agents like Senna, bisacodyl or milk of magnesia, which you'll sometimes see abbreviated as MOM or MOM. And then we have bulk-forming laxatives like Psyllium or Metamucil. Dr. Brandt, what are some of the important things to remember about Psyllium and our other bulk-forming laxatives?
Oh, absolutely. It's not one of my favorite because oftentimes our patients aren't getting adequate hydration, and these agents can really build up in their system. Actually had a patient who experienced a basic an issue with his bladder and his bladder bowel issue where he couldn't go, and it caused him so much discomfort because he was using too much psyllium and not getting enough hydration. So I'm not a big proponent of using agents like Metamucil in using for treatment for constipation.
And
Absolutely.
it would be contraindicated if they're on an opioid also, right?
Absolutely.
Yeah.
Thanks.
Some of the other agents we have in our arsenal include osmotics like polyethylene glycol or Miralax, and then rectal suppositories. So these aren't always as fun for patients or caregivers to administer, but if you have something that's really not responding to some of these agents, the use of a rectal suppository or enema could be the relieving factor. Then we have this new fancy class of medications called PAMORAs, and this stands for peripheral acting mu-opioid receptor antagonists. That's a huge word. What this really means is that they're agents that counteract the effect of opioids to reduce the incidence of opioid-induced constipation. It's important to remember, however, that these are only effective for constipation due to opioid therapy, so they will not work for any other type of constipation. Some of the available agents from this class include Relistor or Movantik. Nausea and vomiting. So nausea refers to the presence of upset stomach, which is often accompanied by the feeling of a need to vomit or throw up, whereas vomiting refers to the forceful expelling of the stomach contents through the mouth and or nose, which does not sound very comfortable. You'll see nausea and vomiting in a lot of disease states such as kidney failure, stomach or colon cancer, and also from medications. And I think we always talk about some of the common side effects with medications. Pretty much anything will cause nausea, vomiting, or diarrhea. But really our common culprits with this are the antibiotics, opioids, and again, chemotherapy. Patients who get radiation of their GI tract for different types of cancer will also experience nausea and vomiting. And like we mentioned before, constipation and bowel obstruction will cause additional symptoms with nausea and vomiting. If you have really bad pain, this could be another cause, and even emotional distress and anxiety. When should you be talking to a nurse or prescriber? Well, anytime the patient reports an upset stomach or feeling queasy, if they can't keep food or fluid down, general lack of appetite. So if every time you try to eat a meal you just throw it right up, you'll probably stop eating. And constipation. Report any potential triggers that the patient tells you about. One of the common ones is thinking about chemotherapy. So if you got a dose of chemotherapy that caused severe nausea and vomiting, when you know it's time for your next dose, you can actually develop nausea before you even get the drug, and we refer to this as anticipatory nausea and vomiting. Strong foods are other triggers, especially things like fried foods or very spicy foods. How do we go about treating it? Some options for non-drug therapy include hypnosis, acupuncture, or acupressure, but a big component is avoiding triggers. So Dr. McPherson, if the smell of fried foods makes you feel nauseous, should you go get some KFC?
No, that certainly does not sound like a good plan to me. I would. People's tastes do change, as particularly with some diagnoses such as cancer. But if they know just by smelling the odor of the food, and sometimes the temperature of the food too, can be very off-putting. So I would be guided by the patient's preferences.
I think that's great. For medications to treat nausea and vomiting, we have a lot of different options. Prochlorperazine or compazine, which can make patients feel a little sleepy. And actually, haloperidol. What's that doing on the list, Dr. Brandt?
Oh, you mean on the medication list, the Beers criteria list you're talking about, or just haloperidol in general? So haloperidol, as we know, is an antipsychotic, and it gets scrutinized because sometimes we're using it off-label for dementia-related behaviors. But I think the safety perspective that comes with the class of antipsychotics, we're going to discuss a little bit more later. But we do know that this particular agent not only may help with end-stage delirium, but also may help with the nausea, vomiting as well. So if we can justify its appropriate indication and use and look at those risk benefits, and I think that's the key discussion when we talk about agents like haloperidol.
Absolutely. And what I tend to see is that you'll need lower doses of haloperidol for relief of nausea and vomiting, whereas if they're using it for one of the neuropsychiatric indications, those are typically at higher doses, although that's not a hard and fast rule. Other agents are metoclopramide or Reglan, and ondansetron or Zofran, which is indicated for chemotherapy-induced nausea and vomiting. Because of this type of symptom, patients may not be able to tolerate the oral route of administration. So a lot of these come as soluble tablets that dissolve in the mouth, and also rectal or IV formulations that will not get thrown up if the patient is persistently nauseous. Mr. Peterson is a 91-year-old male. During a visit, he complains of persistent nausea and that his belly has felt full for several days, and food is just not that appetizing anymore. He has not had a bowel movement in over 5 days, which he attributes to these new pain medications that the doctor is giving me. So it sounds like this guy has a lot going on. Dr. McPherson, what do you think?
I think he's constipated, and the constipation is causing the nausea, a very common cause.
Think you might be onto something. So based on Mr. Peterson's description from his symptoms, you suspect that he's suffering from A, nausea, B, constipation, C, nausea and constipation, or D, cachexia.
I'm going to go with C.
You are right on the money. So this patient is experiencing 2 different symptoms that are closely intertwined. With that, we conclude non-pain symptom assessment and management, Part 1. We'll see you back here for Part 2.